I am Anastasia from Group C110, and my team members and I will be presenting a case study of cervical cancer. My fellow team members are Floel Vera, Nur Jahira, Putri Nordiana, and Saiful Aizam. This case study consists of a bit of introduction, case presentation, disease process, management and outcome, and nursing care plan. So, what is particularly interesting about this case? Why do we choose this case? First, the patient presented with persistent vaginal bleeding for 3 months since June 2024 before seeking medical attention. This shows the need for early screening, as cervical cancer is largely preventable and treatable if detected early. Despite the severe symptoms, there was no history of a previous core biopsy or routine cervical screening such as pap smears, which may be caused by the patient's level of knowledge of her condition. Besides, the patient's care becomes more difficult when hyperthyroidism is present. Her ability to handle the stress of treatment, radiation, and chemotherapy may be impacted by hyperthyroidism. Moreover, the lack of screening history may likely delay early detection of cervical cancer. The bleeding episode immediately following the examination indicates increased tumor fragility or vascular involvement, which complicates both staging and management of her condition. Apart from that, thyroid dysfunction can complicate chemotherapy tolerance and radiation-induced side effects. Besides, managing active bleeding while initiating definitive treatment such as brachytherapy, external beam radiotherapy, EBRT, and chemotherapy can be clinically challenging.
Biographical data. Madam Noraida is a 38 years old Malay female patient from Cebu with stage 2A to cervical cancer. She is married and blessed with 1 child, not working, and has no history of allergies. Moving on to the chief complaint. On 14th of November 2024, Madam Noraida rushed to the ETD of STH when she experienced facial numbness, upper limb tremors, felt cold, and is shivering. She reportedly had brachytherapy on the 9th of November 2024. Let's start with the vital sign for the presenting symptom. The patient blood pressure was 138 under 79 mm mercury. The pulse rate is 77 beats per minute, respiration rate of 20, body temperature of 36.7 degrees Celsius, oxygen saturation of 97 under room air, and pain score of 7 out of 10 at pelvic area. Patient appears slightly pale and alert, has no problem in ambulating but easily fatigued. Patient is experiencing urinary frequency, whereas she will need to go to the toilet every 1 to 2 hours, and she also has irregular menses, whereas it will come too soon or too late. Next, past health history. Patient was firstly diagnosed with cervical cancer, stage 2 at 2, in the end of August 2024. She started for weekly brachytherapy on 7th November 2024 and started her weekly chemotherapy on the 9th of October 2024 with IV cisplatin and currently in the 3rd cycle. The patient has underlying hyperthyroidism, and having follow-up at KPJ Cebu, she also had hard time accepting her condition at first because everything was too fast for her.
Next is assessment. For physical examination, patient general appearance pale positivity, which is nice, alert but fatigue, no fever. For abdomen, slightly tender lower abdomen, no palpable masses, and no signs of peritonitis. For pelvic examination, lacerated cervical mass with bleeding, blood clots present. Patient also have difficulty performing daily tasks due to anemia symptoms and emotional distress related to diagnosis of ongoing treatment like brachytherapy. Next, based on patient laboratory results, hemoglobin was increased from 9.6 grams per deciliter and magnesium is 0.09 mmol per liter. Anti-SH is 22.6, which is elevated at hypothyroid state. Based on clinical findings, vaginal exam, GI radiation dermatitis over the perineum, cervical tumor, first MAP and 5 cm wide, left parametrium involvement at right, and based on laboratory results, cervical mass 5.4 times 5.1 and times 5.3 cm with replacement of endocervical lumen, and bilateral complex at nexus with left pelvic lymphadenopathy. Minimal fluid in the pelvic and abdominal region, sigmoid polythickening, which is inflammatory or infective origin surface, and cardiomegaly and fatty lymphoma. Next is disease process. Cervical cancer is a malignant tumor that develops from abnormal growth of cells in the cervix, the lower part of the uterus that connects to the vagina. The primary cause of cervical cancer is persistent infection with high-risk strains of the human papillomavirus (HPV), a common virus spread through sexual contact. In most cases, the immune system clears the HPV infection, but in some people, the virus persists for years, leading to DNA mutation in cervical cells. This mutation causes uncontrolled cell growth, forming a tumor that may invade nearby the tissue and spread, which is metastasis to other parts of the body over time. Cervical cancer often asymptomatic in its early stage. As the disease progresses, common symptoms include abnormal vaginal bleeding, state intercourse between periods or after menopause, heavy and prolonged menstrual bleeding, watery or bloody vaginal discharge with or cold odor, and pelvic pain or discomfort during intercourse. HPV infects the epithelial cells of the cervix during sexual contact. The virus integrates into the DNA of the host cells, disrupting normal cellular function. Resistant HPV infection, especially high-risk type like HPV-16 and HPV-18, cause abnormal change in the squamous epithelium. This change leads to the development of cervical dysplasia, Cervical dysplasia is classified into three grades based on severity of the normal change, which is CIN1, mild dysplasia involving only lower third epithelial layer. Second is CIN2, moderate dysplasia involving lower two-thirds of epithelial layer, and CIN3, severe dysplasia of carcinoma in situ involving full thickness of epithelial. Without treatment, the dysplasia progresses into invasive cervical cancer. Cancer cells invade deeper tissue of the cervix and may spread to surrounding ligaments, nearby pelvic organ, or distant sites such as the lungs or liver. The types of cervical cancer are squamous cell carcinoma, which originate in the fat cells lining the cervix. Next is adenocarcinoma, which begin in rectangular cells lining the cervical canal, mixed carcinoma, which has feature of both squamous cell carcinoma and adenocarcinoma. Cervical cancer is assessed into 4 stages. Stage 1 is confined to the cervix, without spreading to lymph node or other areas. Stage 2 involves growth beyond the cervix to uterus, possibly reaching lymph nodes. For stage 3, it spreads to the lower vagina of the pelvis and may obstruct the uterus. Stage 4 represents advanced cancer, spreading to distant organs like the lung, liver, or voice. Several risk factors include likelihood of developing cervical cancer. Resistant HPV infection is the most significant risk factor. Others include smoking, which expose body to the procedure. Having multiple sexual partners or engaging in sexual activities at early age, or co-infection with other sexually transmitted infection, such as HIV, breast, or weakened immune system, and exposure to diethyl steroids through TS during fetal development. A family history of cervical cancer also can increase susceptibility to long-term use of oral contraceptive as linked to a higher risk of cervical cancer as they do not protect against HPV infection.
Next, I will be presenting about the management and outcome. So for the management, the first thing that we do is for the assessment and evaluation. We ask the patient about her history of vaginal bleeding, especially during postnatal or postmenstrual. We also ask her about the present of pelvic pain and also any unusual discharge from her vagina. And also, we have performed a physical assessment to assess the patient's pain level and discomfort, and any sign of anemia, for example, like pallor, fatigue, short of breathness, and tachycardia. We also monitor the patient's food intake and monitor the blood test, means patient present with electrolyte imbalance. Next, for planning and intervention. For symptom management, we had administered analgesic such as tramadol to manage pain felt by the patient. After that, we ask the patient to rest in bed, and since the patient is still going for brachytherapy, we monitor any side effects. After that, we assist in care of the patient during her chemotherapy. So for the nutritional support, we advise the patient to eat nutritional food, especially during the treatment, to support the immune system and to recover from the treatment like chemotherapy and radiation. After that, for physiological support, we provide emotional support and active listening and also the reassurance to reduce the anxiety felt by the patient. We also refer the patient to counseling if she was having a problem regarding her anxiety and about her disease. So, and the last one is for education and health promotion. We remind the patient to always adhere to her treatment plan. Next, for monitoring and evaluation, we regularly assess for any sign of complication of the patient, for example, like nausea, fatigue, or vomiting due to chemotherapy, and also the skin changes or discomfort due to radiotherapy. We also perform the full blood count to monitor for anemia, and we evaluate the patient's emotional well-being and coping mechanism. For collaboration, we work under the supervision from the registered nurse and also the clinical instructor. We also collaborate with the multidisciplinary teams such as dietitian to provide holistic care. Next, I will be presenting about the expected outcomes of the patient. So for her physical health outcome, this patient will be able to verbalize the reduce of pain with pain score of 0 to 1. She will also have a stable vital sign and improved nutritional status and adherence to the treatment plan. After that, for the emotional and psychological outcomes, she will be improved in emotional well-being through support and counseling, and patient will have a better coping mechanism to deal with the disease and side effects of the treatment. For quality of life, the patient can maintain her hope and positivity throughout her treatment. The last slide that I will present is about the indication for completion of treatment. This treatment is finished when the prescribed treatment plan is complete. Why? Because the cervical cancer treatment are often scheduled for a defined duration, for example, like 5 to 6 weeks of chemoradiation, unless there's interrupted by any complication. How? It is concluded when the full course of therapy is complete without the need for acute phase inspection. So in this patient, there is no termination of care was done since the patient's treatment is still ongoing and the patient did not refuse to get the treatment.
So the first nursing diagnosis based on objective and subjective data is electrolyte imbalance related to brachytherapy as evidenced by low magnesium level, facial numbness, upper limb tremors, and body weakness. For the goal, short-term goal, the patient will maintain normal electrolyte level during hospitalization as evidenced by stable serum potassium, sodium, calcium, and magnesium level. For the long term, the patient will report no symptoms of electrolyte imbalance such as muscle weakness or cramp over the next 3 months. First intervention, regularly monitor serum electrolyte level, potassium, sodium, calcium, and magnesium through blood tests. Rational early detection of imbalance allow for timely intervention to
Prevent complication. Second is assess and monitor the patient for symptoms of electrolyte imbalance such as muscle weakness, cramp, confusion, and cardiac irregularities. The rationale of this is to identifying symptoms and early helps in prompt management and prevention of severe complication. Next intervention is administer prescribed electrolyte supplement as needed, for example, normosaline, potassium, calcium, or magnesium. This is to correct deficiency, help maintain normal electrolyte level, and prevent symptoms. Next is educate the patient about the importance of maintaining electrolyte balance. This is to empowering the patient with knowledge, help them take an active role in managing their condition and preventing imbalance. Okay, last but not least, encourage adequate fluid intake and monitor fluid balance. This is because proper hydration help maintain electrolyte balance and prevent dehydration-related imbalance. For evaluation, short term, the patient was able to maintain normal electrolyte level as evidenced by stable lab result during hospitalization. Long term, the patient was reported no symptom of electrolyte imbalance such as muscle weakness or cramp over the next 3 months. Second intervention is impaired urinary elimination related to tumor pressure on the bladder as evidenced by increased frequency of urination. For the short-term goal, the patient will report a decrease in the frequency of urination within 1 week. For the long-term goal, the patient will report a decrease in the frequency of urination within 1 month. First intervention, strict input and output charting. The rationale is quickly identify any imbalance such as dehydration or fluid overload and intervene promptly to prevent complication. Second is encourage the patient to maintain adequate fluid intake and unless contraindicated. This is to ensure proper hydration, which can help flush the urinary system and reduce the risk of urinary tract infection. Also, teach the patient bladder training technique to increase the interval between voiding. This helps to improve bladder control and reduce the frequency of urination. Next is administer prescribed medication such as anticholinergic or alpha blocker as ordered. This medication can help relax the bladder muscle and reduce symptoms of urinary frequency. Next, encourage patient to use urinary catheter for accurate urine output monitoring and facilitation of healing, especially patient with mobility impairment. Next, regularly assess for signs of complications such as urinary tract infection or renal impairment. This is because early detection of complication allow for prompt intervention and prevent further deterioration of the patient condition. Evaluation for the short-term goal, the patient was reported a decrease in the frequency of urination within 1 week. For the long-term, the patient was reported a decrease in the frequency of urination within 1 month. Last nursing diagnosis is acute pain related to pelvic pain as evidenced by patient complaint pain score 6/10. For the short-term goal, the patient will report a reduction in pain level to a manageable level 3/10 within 24 hours. For the long-term goal, the patient will maintain pain at a manageable level 3/10 or less over the next week. The first intervention is assess pain characteristic using standardized pain scale every 2 to 4 hours. Rational, accurate assessment of pain help in planning and evaluating the effectiveness of pain management strategy. Second is administer prescribed analgesic, for example NSAID or opioid as ordered. This is provide pharmacological relief of pain, improving patient comfort and ability to participate in activity. Next intervention is implement non-pharmacological pain relief methods such as heat or cold application, relaxation technique, and distraction. It is because complementary method can enhance pain relief and reduce the need for medication. Next intervention is assist the patient in finding a comfortable position that minimizes the pain. Because proper positioning can reduce strain on affected areas and elevate the pain. Last but not least, monitor the patient for side effects of analgesics such as nausea, constipation, or respiratory depression. This is because early detection of side effects allows for prompt intervention and ensures patient safety. For the evaluation short term, the patient was reported a reduction in pain level to a manageable level 3/10 within 24 hours. Long term, the patient was able to maintain pain at a manageable level 3/10 or less over the next week.
In conclusion, this case highlights the diagnosis of advanced cervical cancer, likely worsened by delayed detection due to the absence of prior screening. The patient presents with persistent bleeding and symptomatic anemia, which requires immediate intervention and comprehensive treatment. The management is further complicated by active bleeding and hyperthyroidism, which could affect the treatment tolerance. This case underscores the critical importance of early screening, timely diagnosis, and a multidisciplinary approach to manage both the cancer and related conditions. So these are the references that we use in this case study. And that's all from us. Thank you.